Okay, so we had been, as you said, so we had been probably making plans since the beginning of March. So we had been looking closely to see what was the advice was coming out. I think I had an idea that we were probably going to lock down from the 23rd. I thought as soon as the schools went, that would be it. So initially, obviously, we looked at who our most vulnerable patients were. Now you can argue that all our patients are vulnerable, and they are, but we have, we have certain people who are more vulnerable than others. So, and also certain people where looking at the people who we still needed to be visiting and the people who it would be better if we managed it in a different way to protect them. So what we did was, if we obviously had done lots of work in regard with the community, with looking at how we were going to manage lockdown, look at how we were going to manage dying within the community. We looked at how we were going to manage, and I think we have to think about the fact that actually, while most people think about the fact, will think of the hospice as the inpatient unit and the community teams and the day hospice, etc. We also manage the hospital palliative care team. Obviously, when we came to lockdown, we'd done a lot of preemptive work. Day hospice, we had to close to the patients coming in, and we moved that to doing weekly phone calls to patients and their families to see how they were doing, because obviously a lot of our day hospice patients, we are their social support, they're not necessarily seeing the community palliative care team because they're seeing the day hospice every week. So that very quickly went to telephone support and managing anything that came up that way. With the community palliative care specialist nurses, a lot of their work went to telephone calls, because for lots of the patients they were shielding, and so we were trying to protect them by not going in unless we really needed to. So then it went to a lot of telephone support, but also, and then just visits when you had to go. There was no other way of managing that. You had to go and see them. So that changed their practice, because the CNSs are very good at thinking, oh, I'll just nip round and see you, and actually they had to really think about whether that was the most appropriate way of dealing with that. Lymphedema, again, we obviously had to close to patients coming into the hospice because we were all in lockdown, and so we then again went to how can we manage that either over the phone or virtually. Or also we did Sue did some home visits with the DNs. So we sort of look again, it was how could we adapt our practices to get into to support our patients at home. Inpatient wise, I mean, that was probably the inpatient unit and probably the hospice at home team, that was just and the hospital team, that was where the biggest change happened, because suddenly we had to do palliative care and end of life care through a mask, through gloves and through a pinny. And a lot of our work is done recognising facial expressions, the use of touch, and all those things changed. Having to tell someone that their dad was dying either over a phone, which is often what we were having to do, especially with a hospital, the hospital team, or with a mask on. I mean, 28 years of palliative care, I've never had to do that, never had to hold someone's hand in just a glove. It was all very strange. Also the fact of when we went into lockdown for the inpatient unit, not having relatives there. There is lots of our work which is support to relatives, and suddenly we weren't able to do that in the same way. We were doing it over the phone, but again, it's not the same as sitting with someone by the bedside and giving that present support. That's the way I would explain it, you know, that you are just there with them. You may not be having to say a great deal, but you're just there with them. And suddenly we had to change all that as well. And lots of the nurses spoke about the fact that actually it was really strange not having relatives in. We were, you know, so we then changed, because then what we did was we went to a lot of different ways of communicating. So we got the iPads, and we got Skype, and we got FaceTime, and we did lots of phone, lots of conversations that way. We managed to FaceTime or Skype Australia so they could talk to each other. You know, so there was lots of that, and that was very interesting because some of my staff are not very technically minded, so they were learning huge new skills about how to manage this. So there was lots of different ways that we were using for different people, but it was strange. It was very strange, and it still is very strange. One of the big challenges was the speed of change that was going on, and every time we thought we were on top of what the new PPE was, what this was, what that was, all changed again. And so then you had to make sure that everyone was wearing the right PPE, that we knew what we were doing, all that sort of stuff. And it was just constant new advice, new information, and making sure that was out. I think for me, as the manager, I think what was really encouraging, I don't know if encouraging is the right word, what I was very proud of, there was obviously lots of staff, especially in the inpatient unit, more so than the community, who were really quite anxious and really quite nervous about coronavirus themselves. Okay, they were obviously reading all the stories, they were obviously hearing all the stuff, they were also hearing, stories of staff being, becoming ill with coronavirus and needing to be hospitalised and be really poorly. And they were and also very, very anxious about taking it home to family, and what, the risks that they were doing to their families as well. And we did have, we went through a stage in the inpatient unit where, we had a run of staff just off, to the point where I think there wasn't many staff that weren't off. It was, but the ones that I think, what I found was the amount of flexibility people gave me, so that they would swap their shifts, they would rearrange what weekend they were working or whatever, so that they could cover the unit, so that we had we had the numbers to look after the patients. Was just really fantastic. I mean, they're very good at doing it anyway, but even more so because I had so many people off sick, I was asking the same people all the time, and they, I think we ran, and they just did a fantastic job. I mean, their argument was always, well, I've got nowhere else to go, so I might as well come to work. But I think it is, that sort of thing, the care they wanted to give, some of the compassion I've seen. I mean, they're always very compassionate anyway, but some of the compassion that I've seen, I think, has been huge this time, because we've been supporting really distressed people on the phone, or we've had people that have said goodbye in the car park because we've had to do the only one person can come in, and they've managed that so well. Yeah, the hospice at home girls did a sterling job. They saw lots of patients at home, and kept lots of people at home, and so that they didn't have to come in. And I think one of the beauties about that was we were still quite a new team in a way when COVID really started to raise, but the relationship between them and the district nurses has hugely improved, because I think there was so much collaboration that needed to be done, because obviously everyone was having issues with sickness and also the amount of patients who were dying at home increased, because people didn't want to come into hospital. They didn't want to come into hospital. They didn't really want to come into the hospice because of the fear of getting coronavirus if you came into the hospital or into the hospice, but also because you had to, the limitation on visitors was huge. So there was lots of patients, not just the usual patients that we would have been involved with, but I would say lots of other illnesses and of patients that stayed in the community because families didn't want to bring them in. And so I think for the hospice at home team, they obviously were really quite busy through that time, but also their relationship with the DNs changed, and they became much more collaborative and much more seen as a team, which was brilliant, which is what we always wanted. And so that's been really useful. And also their relationship with the palliative care CNSs has been really good, because the majority of our CNSs are prescribers. And obviously we had the challenges of lots of the GPs were working away from the surgery, and how could we get a prescription change, and so the community CNSs really helped in that when that was difficult, because sometimes it was just going to be quicker and easier to do it that way than trying to work out with the GP how you were going to do it. So I think the relationship there really grew as well for the team, and I think for us as an organisation, we did lots of work with so Helen did lots of work with the GPs about, and supporting them about how we were going to manage this in the community. We did lots of mutual support with ourselves in Rennie Grove, with our partners in the south, because obviously we needed to think about how we were all going to do this, and PPE. We were facing the same challenges, so I think what's been really impressive to me is the way that we've worked so collaboratively with so many people, and how a lot of that happened in a very short period of time. We opened the hospice up probably a little bit earlier than other people, because one of our biggest issues was visitors, and I think that we have to think about the impact of the not saying goodbye, the impact of all that sort of stuff, the not being able to visit. So one of the biggest challenges I think throughout this period, and actually for us, especially in the inpatient unit, is the fact that we don't see the patient by themselves. We see the patient as part of their family, and obviously one of the strangest things has been us not allowing visitors in, and we've always let someone in who, for the patients that were dying, but that was only one patient, one patient, one family member. So, you know, because that was what the recommendation was, and we were following a recommendation. So you then had families facing a really difficult choice on who got to be that one person that came in. And lots of families, you know, we had, well, not lots of families, but we had a couple of families who really got upset, who were really asking, could they not come and stand in the garden, could they not come and do, you know, whatever. And that was really difficult. Not only, I mean, it was difficult for the staff, but not because they were having those difficult conversations, but because they felt so, it was so it was so against everything we stood for in hospice care. You know, the whole thing about the patient is part of the family and the family is part of the care. And so what lots of staff found that really hard, that they were not allowed, you know, that they were not allowing to, they were having to have those conversations saying, I'm really sorry, but I can't allow you in. And so we had lots and lots of conversations about, oh God, lots of conversations about visiting and stuff like that. And we kept changing our visiting things all the way through. So initially, at the real height of coronavirus, when everything was in lockdown, we just had the one person coming in who was the person that, for the person that was dying. And then we realised that there was lots of patients, that, especially our symptom control patients, and I was hearing this from our community CNSs, of patients who usually would have come into the hospice for symptom control who weren't coming in because they couldn't have visitors. And some of that was okay, and some of that we, you know, I think it showed that we could manage certain things at home, that maybe they hadn't really, that, you know, the CNSs maybe hadn't thought that we could, and so, you know, that was quite a good learning curve for them. But also, I think it made us think about, you know, the patients that were missing out because of the not wanting to leave their family, or the wanting to be able to see their family. And so we then moved to, we still have the one visitor for the person that was dying, but we would allow in for a couple of hours a day for the people who, and again it was one visitor, but for the people that were coming in for symptom control. And so now where we are now, because we keep developing it, where we are now is that we still have the people could come in and visit the patients that are symptom control, and we have, I think we have 2 hours. We're still offering 2 hours, and we're in the bay because, you know, to try and maintain social distances and stuff like that. You know, 1 and 3, bed 1, the visitors for bed 1 and bed 3 can come in the morning, and bed 2 and bed 4 can come in the afternoon, because they're diagonally and we can do the thing. So we've had to think about logistics of how we manage this. Side rooms, obviously, we are people, you know, otherwise people can come in, you know, for that 2 hours. Apart from, and then what we have done, and we started that probably about a month ago now, and that was because we had a number of patients in where it had just felt really uncomfortable about, and we had moved at that point to, you could have one person one day, one person another day, but it still felt really uncomfortable when you had maybe families that were living, you know, the older children had moved home and everyone was living together. So we've moved to the family bubble, the household bubble can come in when someone's dying, and that seems to be working okay at this moment in time. It's still very strange because it obviously means that we don't have as many visitors around as we usually do. We don't, you know, what we are having to limit our, what we're having to do is ask our visitors not to wander around the unit. So we're getting them teas and coffees if they want, rather than letting them go into the relative kitchen like we used to. And one of the shames about that is families used to do mutual support in the family kitchen. They'd go and they'd make a cup of tea, and they would see, the lady who was visiting bed 12. But they might see, because they might come in at the same time every day, they get to know each other. So one might be in one bay, one might be in another bay, one might be in a side room, one might be in a bay. But they would form those little peer support things in that kitchen, which is just another layer of support for them. And we're not able to provide that at the moment because we can't have people. We've got to try and protect people, and we have to try and follow the social distancing stuff, so we're getting their drinks. So it's just another layer of support that I think people are not necessarily getting in the same way. And the other challenge we've got within the hospice now is that every patient that comes into the hospice needs to be swabbed for COVID, and that nationally that's what's happening with everyone within the hospital. So obviously that adds new challenges to us, because what we need to do if they're coming from the community, we need to put them into a side room so we can swab them, and then when we get the swab back they can go in the bay. So it's that meaning that sometimes it's not as easy. If we've got a lot of admissions on the same day, it can be challenging how we manage that. But I think we're still getting. I think we're still giving a good standard of care. We're still giving a compassionate care, and that's what we're about, really.